Dr. Dunaway, welcome back to the show, sir.
I'm glad to be here again.
I'm going to make you play favorites here for a second, which is never comfortable.
Fantastic.
But I think it's important.
Love it when I don't know what's coming.
Who is the best thrust manipulator to ever graduate from South College? And they can't have manipulation experience coming into South College. I know we've had some chiropractors who, over the course of the program, wound up at the end, you saying, that is the most skilled anybody's ever gotten at the psychomotor proficiency of thrust manipulation in all of your years of teaching down there.
Wow.
Yeah.
You really put me in some of these students.
You're going to get a lot. You're going to get a lot of feedback from. Yep. I'm going to make you answer.
The problem is there's so many.
They do an incredible job.
So many highly talented students. And if I don't say your name right now, I'm sorry. You all are crushing it. I got to say it's either Jesse or Miller.
Yeah.
Jesse Witherington, Miller
Armstrong.
Jesse's thing too, though, is like I hadn't met her yet.
Yeah.
And she was presenting for the IOMP SIG.
Yep.
And she just emailed me randomly, said, hey, Dr. Dunaway, would you be willing to look at I recorded myself teaching this for the thing. Would you be willing to watch this?
Yeah.
And I watched her teach this on video, how she wanted to present it. And I was like, wow, this woman has got such innate teaching skills and her hands are so solid. Like she was on the radar from then on out. Nice.
What percentage of students, and we're going to get into some thrust research and we're going to do all the things, but I'm just curious, your honest gut response, like what percentage of students do you see graduating from South where you feel like they're comfortable at a level, and I know that you all are doing some research in this space, that they're going to go out in the clinic and do it execute spinal thrust manipulation on a reasonable percentage of their patient population?
At graduation, I think it's hard. So yeah. I would say, so we've got roughly 100 students per cohort.
Yep.
Of those going into outpatient when they graduate, I bet you it's a fair amount. I bet you it's I would say 60-70%. Is my guess.
Yep.
Because I think, we do a really good job teaching it, layering it in through the curriculum.
Yeah.
My issue is I think that, and I guess we're going to get into this.
Let's do it right now. Let's just dive into the research you all are doing and how you're investigating this topic.
Yeah. So my feeling, you and I both have been traveling the country for 12 years teaching manipulation. I always kind of start with, I ask, what's your experience? Did you learn it in school? That kind of stuff. And what I learned is it's all over the map.
Totally.
But a story that I frequently hear is that I learned it in school. I went out on clinical rotations. My CIs weren't doing it, so I couldn't do it. And then when I graduated, it was like a thing that I felt was important, but I was terrified to do it to real humans. I hadn't done it in a year, so I just kind of let it fade. So we wanted to say how common is that? So we picked 3 schools that we know. We partnered with Baylor and Hawaii Pacific. Okay. So I know at Baylor you got Louis Puentedura, who has been the leader in the space forever teaching it. At Hawaii Pacific you've got Paul Minkin, a leader in the space who's teaching it, and then I'm teaching most of manipulation at South. So we know those 3 schools are getting good manipulation training.
Yep.
So we surveyed the students. We want to see what is your comfort level before you're exposed to this for cervical, thoracic, lumbar. And then after it's taught in the curriculum, we survey them again. What's your confidence level performing these skills? And then we're going to do it again once they get back from their final rotations before they graduate. My hypothesis is that their comfort's going to grow through the curriculum.
Yep.
And then they're going to get on rotation, and then we're going to see a dip. And they're going to leave the program less confident in the skill than they were after they learned it. And I think that speaks volumes to where the profession's at with this skill.
What are you hearing from the students? My CIs don't do much of it. They don't want me to do it. Like they're actually prohibiting it. What are you hearing from a lot of the students that are out on rotation?
Yeah, that's it. So the CIs don't do it.
Yeah.
Or we don't do it early in the program, or we do it in such a small, like it might be, your general outpatient orthopedic spine pain patient might be 1 in 20 is getting the manipulation on session 13, maybe. Or it's just, this is not a skill that I have, so I can't supervise you doing a thing that I don't have. Yeah. So I get a lot of that. And I get some clinicals where students are doing it, but the majority is it's not happening a lot.
Which is shocking for 2025. I mean, I guess let's start there. Where is the state of the research as of now regarding the efficacy of thrust manipulation in the populations that it should be done on? Because, when I graduated from school, it was way back, in the CPR days, we were trying to identify kind of a home run cohort of presentation or folks. You've been tracking this so closely and still teaching it to this day. Where has that evolved to? What is the current state of affairs? How useful is this stuff from an evidence-based perspective in the clinic?
Unfortunately, I don't think the evidence has evolved much over the last 10 years. And I think that we've got some problems in the research. Okay. We'll get to that in a second. Yeah. But I think stepping aside from that 10,000-foot view, if you look at clinical practice guidelines, and there's some really nice systematic reviews of clinical practice guidelines for the treatment of neck pain and for the treatment of back pain. Yeah. And pretty much every clinical practice guideline out there says that thrust manipulation should be forefront early in the treatment for almost all conditions that are appropriate for conservative management. Yeah. So despite the evidence body saying that this is a thing that we should be doing up front with most patients as part of the package, not as a standalone, we're just not seeing that in practice.
You're teaching this in person many weekends a year. You're seeing clinicians come in and learn it from you. What are the barriers? Because it feels like certainly we've moved past the safety thing, or maybe I just feel that way because I feel like that has been over and over again reviewed, and relative to almost anything else we do, a completely reasonable risk-benefit profile. What is holding people up from incorporating a very quick, very efficient, very meaningful intervention that's advocated by the CPGs?
That's a good question. I think the skill itself can be a bit intimidating.
Just not having the psychomotor proficiency.
Yeah, and it's a little bit complicated. And there's other stuff, like other skills are easier. Like if, it's not hard to learn a decent mobilization.
Sure.
So I think that there's a bit of that. I think that there's this weird spot in the research where it's kind of all over the place. Thrust manipulation is more effective. Thrust manipulation is not more effective mobilization. It all pans out the same in the long run. So I think there's I think due to some of the research issues, I think that there's some bad information out there.
Yeah. That kind of gives people a good reason in their mind to not have to learn it.
Exactly. Yeah. And then I think that because of some of the traditional approaches to manipulation, when the mind frame, the lens was a bit more biomechanical, I think that a lot of people have had poorly done manipulations, and they're like, ooh, that's not comfortable. I'm not going to do that to people.
Yeah.
But that's not the tools issue. That's who's holding the tools issue.
For sure. Take us into the problems with the research. Where do you see some unfortunately performed or designed, trials that you think maybe we could get better information if they were done a different way?
Yeah. So the problem lives in the methodology hasn't caught up with the understanding of what is actually occurring.
Okay.
Right. So when you think about a thrust manipulation, one thing that I think is at least, if not pretty clear, emerging in the evidence, is that it's about stretching a joint capsule or multiple joint capsules quickly, not just peak force, but rate of force development. Right. It's not about, and we'll get into this, it's not about the click or where the click occurs or locking down to a specific joint and reducing motion so you can push through it. It's about moving a thing quickly. And we haven't landed on that. So there's so much different opinions on what manipulation is and isn't out there that when you look at how the manipulation, the technique itself is done, it's all over the map. Like you've got people that are trying to lock everything out and only move one specific joint or one joint very, very specifically. You've got other people that are doing a more generalized technique. You've got really fast movements. You've got really slow movements. And I've been a subject in manipulation trials, and I've laid on the table and been just like wound up and moved really slowly. And there's a tiny, and they're shooting from my lumbar, a tiny little click in like my mid thoracic spine, and the researcher's like, "Oh, got it." I'm like, no, you didn't. So there's that. Like we don't have an agreement on the actual mechanics of what we're trying to accomplish. And then there's this whole thing with what defines a successful manipulation. And we're hung up on the cavitation, which there is a fair amount of evidence to support that there maybe there's a little magic in that, but that's not the main thing. But we can't decide what we should do with this thing. So what I mean by that is what we'll frequently see in research is you've got 3 or 4 trials that are frequently cited. You've got a Flynn secondary analysis of his CPR. You got a Cleveland thoracic study. You got a Dunning study. You got a handful of studies that compared people that made a sound to people that didn't make a sound, pretty low end, looking at neurophysiologic output, changes in muscle EMG and things like that, and found that when you moved it quickly, whether it made a sound or didn't, you had this neurophysiologic change.
Speed was the variable.
Yeah. So then what you see in the research is, just make up a random example. And we're doing a randomized controlled trial on unilateral low back pain. Painful side up on the table, jump on you, it pops. Great. Next patient comes up, put you on the table, jump on you. It doesn't pop. I jump on you again. Now it makes a sound. I put you over the treatment arm. Patient 3 comes up, jump on your back, no sound, jump on your back, no sound. Flip you over, do the other side, throw 2 swings at that, still no sound, and I say, cool, it doesn't need to pop to count. That's what those 3 studies said. You go in the treatment arm. And the problem with that is that if you don't believe it needs to pop to count, then you've got people in your treatment arm that got the intervention, and you've got people in your treatment arm that got 400% of the intervention. If you do believe it needs to pop to count, then you had people in the treatment arm that got the intervention and people in the treatment arm that didn't get the intervention. But the craziest thing is nobody picks a side. They walk that line right in the middle. Like they do both things. There's a few researchers like Paul Mintkin. Anything that Paul Mintkin does, he says, I don't care if it makes sound or not. I'm taking 2 swings at everything. Standardize the treatment arm. That's how we should do it. And I don't think we'll ever answer that question. Been doing this a long time. If you said, Justin, here's 100 people, do the exact same thing on all 100, 50 of them pop, 50 of them don't. So we can finally put this thing to bed. I don't know how to do that.
It's tough.
You can't.
Impossible.
It's impossible.
Problems aside, like you said, the summation of the research, at least most recently, looking in JOSPT at the guidelines I read last, there is an overall summary that there seems to be some benefit in at least the short term. And I think this is where I take issue, just because I think about getting away from the obsession around the research silo and talking about actually trying to help people who are having a hard time. In all my years in clinic, I never had somebody come in and say, Jeff, I don't really care how I feel over the next couple of months. What I really care about is how I feel 6 months from now or a year from now. I've literally never heard somebody say that.
Because short-term results don't matter.
Dude, what they come in and say is my neck is killing me. Like I've got an event this weekend or I'm hoping to do the open or whatever, and it is the short-term change that they are asking for, that they want to pay for, that they're looking to be served in that direction of. And I find it very frustrating that people could, and this is not just manipulation, although this conversation, probably it's the one I've had the most, people will consistently not give credit to manipulation because they'll say it only works in the short term. And clinically, I'm thinking that is exactly what my clients are looking for. Any thoughts on the obsession we seem to have with short-term versus long-term outcomes in this conversation?
Yeah, I think it's totally backwards. I think it's exactly what you said. You got to think about we talked in previous episode, future episode. We talked about this idea that every acute pain patient was every chronic pain patient was an acute pain patient.
Yeah.
And the space where the potential to shift into a chronic condition lives in that short term, right? And if a patient comes in and they're in pain, and you can transiently reduce their pain, increase their range of motion, increase muscle activation, and then get into the stuff that builds capacity, normalizes them, gets them back to life faster, you're significantly reducing the risk of transitioning to the next thing.
And that's what kills me. All these people say, well, it's exercise. I'm like, have you ever actually tried to get someone to move any sort of meaningful load when they have 9 out of 10 pain shooting down the back of their leg? It's impossible. Who would do that? If you can do something to move that 9 to a 4, and now they're like, well, I don't mind moving a bit. I feel quite a bit better. Like I could get some exercise going. What do you think is going to get them to the thing that's going to create these long-term changes you want so bad if you can't get rid of the short-term spike that right now they're obsessing about? Like, how are we not giving credit to the ability to manage something in the short term to do something that matters in the long term? Like that seems so logical.
Right. And it kind of goes back to this idea that, most back pain totally resolves on its own, but also number one cause of disability worldwide, so much of it doesn't.
Yeah.
And it's like, well, let's get them there sooner, and then let's do the capacity building stuff. And the problem, like, again, going back to the research, when we look at it's beneficial when you combine it with exercise, but in the long run, it really doesn't matter what you do, because in the year, whatever the exercise is, in a year, everybody's going to land in the same spot anyway.
Yeah.
But have you ever looked at the appendix in those trials of what they considered exercise? Like, when you look at the exercises they're actually doing and the doses they're actually doing, they're not building capacity. So I think that if we got to a space where we were doing a couple things differently. Thing number one is we agreed that manipulation was more general, region specific, not joint specific. So you're not locking stuff out, which allows you to get a little bit more capsular stretch and a little bit more space and a little bit more speed. If we standardize that piece, we got the manipulations good. And then the exercise piece, we actually dosed exercise. We picked a couple exercises, not 37, and we dosed them appropriately to build capacity, not doing 3 sets of 15 in an RPE of 3 or whatever with a 30-second rest and call that strength, motor control, and endurance. Like, if we fix those two things, I think what we would see in the next generation of research is this stuff significantly outperforms the other thing.
I love that. I'll also say just one more sort of soundbite on the frustration of our lack of giving credit to making short-term change is this idea of making PTs feel like failures if their person isn't still better 6 months down the road. Like, of the clients I've serviced, dude, nobody minds popping in every couple of months. Like, they tweak something or they push themselves pretty hard. They pop in for a couple of sessions. They're feeling better. You don't need to solve everybody's problem for an entire year with 4 sessions to have been successful. If they pop in and they were really flared up and you help them significantly and they're back to their stuff for a few months and they swing in every couple of months for the next few years and are crushing life, dude, that is a massive success. Like, how can you not look at that as having an incredibly meaningful impact on that person's life?
Absolutely. And self-efficacy and agency are two of the things that predict so much of the bad stuff down the road, right? And if you can get somebody feeling better quickly, get them back to doing their life the way they do their life and back in control of that. I think, again, you're increasing agency, you're increasing self-efficacy, not decreasing it. And if they're like, ooh, I'm tweaked, I'm going to go in and see Jeff, he's going to make me feel better, and then I can go back to doing my things quickly. Like, again, you're not allowing that fear, you're not allowing that lack of self-efficacy, you're not allowing the patient to lose agency. You're giving it to them.
I love that. And you're giving it to them quickly. Like, one other thing about spinal manipulation that I've always thought, it's crazy the bar we're asking it to climb over, considering the time investment and cost investment it takes. Even with a good instruction of, hey, John, if you don't mind, I'm going to lie on your side quick. I'm going to give you a quick stretch. You might hear some clicks and pops. After that, you're probably going to feel a bit better. We'll have you pop up and have a look. Even with that conversation and then having the patient lie on their side and actually do it, you're literally talking about an investment of time around 90 seconds. Which it is pretty crazy what we're demanding it to show, considering the level of safety and the time investment. If it's giving you any sort of meaningful, hey, things feel a little bit looser. I feel I could do a little more today. great. That is a tremendous ROI considering the investment.
Yeah, it's about $4.75 in a session.
Exactly. Yeah, we act like it's the only thing you do in a session that costs $150. It's like it was literally 3% of that. It enabled the rest of the session to be so much more meaningful.
Yeah. And that's the other key, right? Is it can't be the only thing.
Totally.
And that's because of, again, that's kind of back to the space of like the how we use it not catching up with our understanding of it, right?
Yeah.
We're not changing mechanical properties in your spine. We're not changing capsular length. We're not doing any of that. We're creating this space where inhibited muscles are disinhibited, where hypertonic muscles are back to baseline, where your muscles are, where your proprioception, your kinesthesia is better, your pain pressure threshold is higher, your ability to tolerate mechanical stimulus, your pain experience is lower. Like you're creating this transient window where you can move better, feel better, and access capacity building movements. And if we don't use that, then it's useless.
Yeah. Because people are going to ask, you mentioned speed being the thing that seems to matter. So just to make sure the listeners are clear, right? The result, like you said, is neurophysiological, right? This change in muscle tone. There's all these things happening, but it seems like speed drives it. Rate of force development seems to drive it. Are there physical principles? Because we've talked a lot about what we avoid, locking, thinking biomechanically. Are there physical principles or psychomotor techniques that you use in courses to specifically enable people to increase their rate of force development specifically? I mean, are there things our listeners can do or tricks or tips that you have to improve the thing that we're saying matters the most?
Yeah, you mean just like things that I could say on the podcast that...
Yeah, I mean, it'd be tough unless they're on YouTube. We don't have a table here, I suppose.
Hey, lay down.
Yeah. But this is trainable.
Oh, for sure. Without a doubt. That's one of the biggest... So one of the biggest things that I see in people that come to the course, I think what's really nice about the course is that I don't care if you've never done it before, you've been doing this for 20 years.
Yeah.
Like we take a bunch of time to build one foundation together, and then we kind of scaffold the skills throughout the weekend. But the biggest thing that I get in people that have been doing manipulation or have trained manipulation come in, and the number one question is always, everybody says I need to be faster. How do I be faster?
Yeah.
And that's like the whole course. If the thrust piece itself, like the speed, most of the speed is going to come from the setup, being set up appropriately, and then if you're in the right position, if your lines of force are pointing the right way, if you're cognizant of what your wrist is doing and why, where your forearm is and why, where your sternum is in relation to their body and why, like if you line up all those things, speed is easy. 90% of speed faults is a body position setup thing, not a I don't have the fast twitch. That's easy to develop.
In cervical and lumbar?
Yes.
Which one do you think is harder?
Lumbar.
I think so too.
And you think about peak forces needed or peak forces demonstrated in the literature.
Yeah.
And lumbar spine is about 5 to 7 times greater peak force than you need in the neck. And if speed is the magic, when you're thinking about if speed is the magic, it's a lot easier to develop. It's a lot easier to move my hands quickly
For sure.
because they don't weigh anything. So it's not hard to get that mass moving.
Yep.
Down in the lumbar spine, I've got to get 70% of my body moving quickly. That's a lot more mass. So it takes a bit more oomph to get that moving quickly.
Yep.
Yeah, but it's still a setup game. If you're in the right position and you've got your, the biggest thing that slows people down in the lumbar spine, one, their hips are not in the right position compared to their target. You want to always think about your sternum should be as close to stacked over your pelvis as possible. And that line, that center of mass line should be as close to your target as possible.
Yep.
And the other thing is most people have either their weight evenly distributed on their feet or they're heavy on the back foot. And when they drop and they land on that back foot, it arrests their amplitude. But if you've got 80-90% of weight on your front foot and you're stacked and you're over your target, and you keep the weight on your front foot when you drop, it's so much easier to move your mass quickly.
For sure.
But everybody tries to thrust faster versus saying, okay, wait a minute. Am I stacked? Am I in the right position? Where's my weight? Once you lean that up, the fast thrust is easy.
This episode is brought to you by Jane, a practice management software and EMR that I use to help keep things running smoothly behind the scenes. When I first started looking for a practice management tool, I wanted something that felt like a teammate, not just more tech to figure out, and that's why I switched to Jane. One of the things I love most about Jane, the support team. You get unlimited help from real humans, even on Saturdays by phone, email, or chat, all at no extra cost. It's easy to learn about Jane in your own time too. Jane's guide is packed with helpful tips and updates, and it's always growing. Maybe best of all, Jane has a wonderful community of practitioners, so even if you're running a solo practice, you don't have to feel like you're doing it all alone. If you're curious about what Jane can do for you and your practice, head to jane.app/demo, and if you're ready to get started, use our code ICEPT2MO for a 2-month grace period on your new account. It's funny because physics still matter, but almost in an opposite way that we thought they did when thrust manipulation first started being trained for physios. When so much of the physics was around facet plane movement, there was still a lot of focus on physics, but now it's really turned to soft hands, fast hands, more general thinking. Physics still relevant, but leveraging it a lot differently.
Yeah. And I would say that with a desire to be specific to a joint, which we also now know is impossible.
Yep.
And the obsession with the sound over the speed.
Yeah.
What that has trained a generation of manipulators to do is lock everything up super tight, which slows you down, and then leverage mass, push harder instead of faster. And that's why manipulate, like when the patient sits up, they're like,
yeah.
I don't know, I made a sound, think you got it. And then they're like sore for 3 days. And you're like, oh, that's totally normal.
Yeah.
That's just a function of using your physics backwards, leveraging mass versus acceleration.
Yeah. Let's talk, now that we're kind of dialed in on rationale and in philosophy, let's talk a little bit about efficacy or treatment target of patient presentation. Let's not spend any more time on the thing that we all agree on. Spinal manipulation seems to carry some pretty significant value in relatively acute, nociceptive driven, mechanical, non-radicular back and neck pain. I think most people would say that's pretty accurate. Someone's got localized neck pain, localized back pain, it's relatively acute, and they have a positive expectation for thrust manipulation. Those people, I don't think will get much kickback anymore. There seems to be certainly worthwhile value there. But who else? How broad do you think we should be using this intervention beyond that one group we all agree on? Where do you see it not being used enough where you're like, man, we are underutilizing this skill set?
Oh, yeah, in lots of places.
Yeah.
I don't know where to start. I would say, so if we think about general presentations, a CT junction technique for the neck-related arm pain, emerging radic, upper limb tension test patient. You side bend away from the affected limb. If that's comfortable in the setup, and usually it is, you see massive changes in upper limb tension test and diaesthesias in the hand, session 1.
Yeah.
Same idea with emerging lumbar radic and the patient that's got this positive slump sign, the TL junction thrust, the non-rotary PA one, wonderful changes there. Main syndrome, wonderful.
Yeah.
Patients that have not neck or back pain, but shoulder dysfunction, positive arc, traditional, I'm going to air quote for the people on Spotify,
Sure.
your impingement signs, that kind of stuff.
Yeah.
Getting in upper thoracic rib, cervical thoracic junction, you see wonderful changes in pain-free like flexion range of motion, which is wonderful. You think about this acute hot tendinopathy patient that comes in that's got pain at 90 degrees of shoulder flexion. You want to start loading that tendon. It's a tendinopathy. Manipulate some stuff. Now you've got 120 degrees of shoulder flexion. Now you get under landmine press today, right?
What about hypermobility?
That's where I was going next.
Okay, yeah, because it's always one that people almost put a no-go sign on, but the neurophysiology doesn't seem to line up with that.
Right, and it's wild, right? It's a no-go because if you look at the textbooks, the textbooks that are like where most NPTE questions come from, right? So the thing that's really kind of our barrier to get into the game.
Yep.
If you look at the contraindications list, hypermobility is an absolute contraindication.
Right.
And that is based on absolutely nothing but somebody's guess and our old understanding of what we were doing for that comes out of the days when we were putting bones back in place. Right? Oh, this thing moves too much, so you certainly don't want to do that because you'll put things out of place.
Yep.
But it's totally wrong. Anecdotally, and I'll get into research stuff too, but anecdotally, I think it's wonderful in your hypermobility patients, right?
Yeah.
One of the whatever there's a million hypermobility syndromes, but one of the most consistent things you see is proprioception, kinesthetic dysfunction, right? They've just got no idea where their body is in space, and a lot of pain and a lot of inhibition in a region. And what you want to do is you want to rebuild strength and you want to rebuild motor control in a space. When you manipulate that region, you turn on a lot of that immediately, and then you can go in and do your stuff to kind of groove in those motor patterns and lock in that increased body awareness.
Yeah.
There's only one study that I've ever found that sort of talked about this a little bit, sort of. And it was a lower end study, but what they did is they took patients that had pain, and I believe they had neck pain, but they were getting a thoracic manipulation, something like that. And they had the machine. They used the kind of the piston machine to objectively measure joint stiffness.
Okay.
And then they used pain pressure threshold to measure pain pressure threshold. How much pressure does it take before you say ouch?
Yeah.
And they split them into two groups. They took people and they manipulated the stiffest segment. And then they took people and they manipulated the segment with the lowest pain pressure threshold. And in the group that you manipulated the stiff segment, they had decreases in pain or pain experience. They had improvements in joint mobility. They had improvements in pain pressure threshold, but not as much as the other group. In the group where you manipulated the painful region, the spot with the lowest pain pressure threshold, they had equal changes in the experience of pain. Mm-hmm. Their pain pressure threshold increased greater than the other group, and they actually had an increase in joint stiffness. And that makes sense to me, right? If I've got a painful region, if I've got inhibition in the spot, maybe I'm a little bit mobile in general, I manipulate that region, I turn back on those inhibited muscles, I'm restoring a little bit of dynamic stiffness.
It's so funny because the narrative is so clean. We agree that pain inhibits musculature, right? We agree that getting some of that deep muscle activation is going to be therapeutic. We don't think that we're bringing anything, beyond these neutral zones or creating, any bone position changes. And yet we're just not seeing incorporation, or it sounds like much research being done. If one trial you've seen, no one's looking at this stuff.
No, and there's one other that didn't quite look at it that way, but it certainly is a gem that gets overlooked that creates a space to deepen this conversation a bit. The Julie Fritz trial, where they looked at soft tissue stiffness objectively, joint stiffness objectively, pain, disability, and multifidus activation. You familiar with what I'm talking about?
Yep.
So they looked at all that stuff. These were people that were positive on the lumbar C-spine rules. So they knew that they would manipulated everybody. Immediate changes in pain, disability, multifidus activation, soft tissue stiffness improved, joint stiffness improved. Sent them away, bring them back a week later. Everything went back to baseline, except for pain and disability still low, multifidus activation high. So we say, well, cool, it's not about the other stuff. It's about multifidus. The interesting piece of the study that nobody really talks about is those that had the greatest improvements in pain and disability and those that had the greatest increases in muscle activation were the ones that had the least joint stiffness pre-test. And that tells me a couple things. One, that we should not be avoiding our hypermobile patients. But two, it goes back to this idea that where this comes from is that quick stretch of the joint capsule. And the more stiff you are, the less joint mobility available, the less stretch is available, the less your neurophysiological output comes from.
Totally.
You always talk about the patient that 70 years, truck driver, has 30 degrees of range of motion, hasn't looked past 30 degrees.
Not a lot to work
years.
with.
You're not going to get a great bang for your buck manipulating his neck.
Can't send much afferent in there.
Because there's no stretch of the capsule.
Right.
So kind of going back to the first thing, like hypermobility all day. And then you just change, like what you followed up with is going to be a bit different.
Of course. Persistent pain states. Centrally dominant patients, Is there therapeutic utility? What can someone reasonably expect in clinic when incorporating thrust manipulation on people that are having what you might call maladaptive responses or persistent pain or centrally dominant hypersensitive pain states? Is there a role for this?
I think it's limited.
Okay.
I do think there is.
Yeah.
You're never gonna. I've been doing this a long time. I've never had a persistent pain patient.
You hit
walk
him.
in, jump on the table, crack his back. He stands up, and goes, "Wow, dude, why didn't somebody do that 15 years ago?"
Yeah.
Like it's like, okay, cool. So I think that you will have, and there's some research to show this too. You will have limited but not impressive changes in pain. You will see some changes in pain pressure threshold. And the other thing anecdotally that I've seen is changes in 2-point discrimination. So then again, you think about this the same way as exercise stuff. You come in, you've got acute back pain. I'm going to manipulate your lumbar spine and then get you loading quickly to build capacity in those tissues.
Yeah.
If you're a nervous system patient, you're going to come in. If I can set you up comfortably for a lumbar manipulation, I'm going to manipulate your lumbar spine. And now we're going to flip over and now we're going to do some sensory integration stuff because I've cleaned up your brain's ability to know where information's coming from. Now we want to get some focused repetition to create positive neuroplastic change. So in that population, I'm not doing it so much to take your 7 to a 6. What I'm doing it is to clean up some of the brain-body connection so that I can run down that neuroplastic change road a bit deeper.
And it makes sense, right? I mean, we talk about the same thing with dry needling. I love when Paul Kaloran, who teaches our dry needling stuff at Ice Physio here, talks about the value of just the incoming afferent information up into the cortex from this really precise needle placement in the brain, the map starting to clean up a little bit by getting this afferent information. I think about spinal thrust. I mean, same thing, right? We're going into this area where you've disconnected from it a bit. Things are real smudgy. And now you're sending in this huge afferent bolus of information. Yes, we get the neurophys, but just the info coming up into the brain has got to be therapeutic in some of those chronic pain states.
It's kind of like putting on some readers, like your brain sees better.
Sure.
No, that's where that is.
Yeah.
And now we train it.
I love that. So many reasons to do it. So many people to help. How long, leveraging your teaching history, for someone who's listening to this and they're like, oh man, I got some of that in school, but I never really did it. I kind of did the whole mobilization is good. I don't really want to spend the time learning it. It feels like high pressure at the moment of truth. Like I'm just going to not do it. Someone hearing this and saying, all right, I'm going to jump back in. How long does it take somebody who's committed to getting better to get to the point of in the clinic, they've got a proficiency, they're pretty comfortable on most of these folks, giving it a good at-bat?
Yeah. I've been doing this, 12 years.
A lot
teaching.
of reps.
Yes. I'm very confident saying that somebody walking in the door with no skills,
no clinical experience,
have not done this before, at the end of the weekend will be comfortable doing a handful of these techniques on patients on Monday.
Yeah.
But it's one of the biggest things that I tell people is, and I think one of the biggest barriers is kind of that fear, like doing it to somebody who needs it. Like Sarah's neck hurts.
For sure.
And it's like your hands are a little shaky, they get a little clammy. No amount of practice on friends and family will make you comfortable with a patient. Treating patients make you comfortable with patients, right?
Yep.
And walking out of the class, like you have the skill sets. And I'm not just saying that because like I teach it and I'm like, I want, you know what I mean?
Sure.
I get the emails on Monday, on Tuesday, like, oh my gosh, my 9 a.m. I just did this technique for the first time. And she sat up, we high-fived, it was awesome.
Hell
like
yeah.
I could fill a folder with these emails.
Yep.
I think that you can get comfortable practicing on people who need it at the end of the weekend. And then I think you learn the tools and kind of the feedback and how you can develop your skill over time.
Yep.
And that's the other big thing is like, there's always space to improve. If my hands don't look different 6 months from now than they do today, after 15 years, I'm not doing it, right?
Totally.
There's always room to practice. There's always room to get better, but you can be in 16 hours of super focused training, you can be comfortable on Monday. And it's different than PT school, right?
Yeah.
Because there's so much stuff to learn in PT school. And even other courses that do some manipulation, like you learn that, but then you go on to other stuff. It's not like you're getting focused repetitions and folding in skills over 16 hours.
Yeah. One more question, because I think too, there's another subgroup of folks listening to this who have a skill set, but don't do it very often, but are comfortable trying it. How has if they want to get back after it and start doing this with patients, how has your narrative to the patient changed? Meaning that you've identified that you're going to do a spinal thrust manipulation on Mary.
Yeah.
What is your explanation to her pre-thrust? What's, because I've heard, dude, that has changed. I have heard so many wild variants. I don't mean that in a bad way, just so many wildly different narratives over the years. Where have you kind of landed when you're beginning to incorporate this in clinic, explaining it to the patient?
Yeah, let me tell you where I landed.
Yeah.
I'll tell you a thing that I used to say that I don't anymore,
Please.
very specifically. But yeah, I try to keep it as simple as possible, because I think the more detail you put into the explanation, the more like the patient starts
Why
to
we
think,
built
wait,
this up? Yeah.
Well, wait a minute.
Should we be doing that?
Yeah, exactly. And I'm going to say a word in here, which I actually don't believe or why I'm doing it, but I think it's an easy narrative for the patient.
Okay.
But I'll have done my range of motion exam, over pressures, done all my stuff, put you on the table, done some joint mobility stuff, and I'm like, you just feel a little stiff right here.
Yeah.
What I would love to do is I'm just going to give you a quick stretch from here to here. And while I'm talking, I gently move their head like 20, 30 degrees, like we're talking about neck. Gently move their head 20, 30 degrees so they can feel it. I'm going to feel a little stiff here. What I'm going to do is just give you a nice quick stretch from here to here. Yeah. You might feel some pops and clicks, you might not, but when you sit up, you're likely going to feel better. Is that all right? Just like that.
Yeah.
It takes me 10 seconds. I say it fast on purpose because I want...
You can tell you got a lot of reps. Patient can tell you got a lot of reps.
When I say it, it sounds like I've said it 100,000 times.
Yeah.
If it sounds like it's the first time I've said it, then you're thinking, is this the first time he's done this? Yeah. I don't put it on this giant pedestal. I don't want any surprises. Might pop, might click, might not.
Yeah.
When you sit up, you're likely going to feel better. I want to implant that positive expectation in everybody.
Sure.
With all things.
Yeah.
Just the volume of research.
And you wouldn't be doing it if you didn't think it probably would feel a little better.
Right.
Yeah.
Yeah. I know it's going to feel better.
Totally.
But I need you to think when you sit up, you're going to feel better because that just enhances the outcomes.
Totally.
There's just so much research there.
Yep.
I said I'm going to stretch it because it feels stiff. I am not stretching it because it feels stiff. I'm not changing stiffness in that way. It's going to move better because the muscles are moving better. What the patient doesn't have time for is an hour lecture on the neurophysiological effects of thrust manipulation.
Yeah.
Tight stretch. That's a narrative that makes sense to the patient.
I love that.
And that's it.
What did you used to say that you don't say anymore?
I used to, and this is how I was trained in the beginning.
Yeah.
I used to say that, it's going to make a sound. Like there was no ambiguity there for sure.
Oh, interesting. You didn't leave any wiggle room there. We're going to crack this thing.
It was going to pop.
Interesting.
And it's totally normal to feel sore the next day for a little bit. And
you feel as your hands have softened up, as you've moved quicker, not necessarily harder.
I think that's half of it.
Okay.
I think that's half of it. I think that in the beginning, my patients certainly came back and said, oh yeah, I was a little sore the next day, but I feel pretty good now. That was the thing I heard all the time. And I think part of it was certainly that. Like I was chasing the sound. I was a bit stiffer in my setup. I was probably swinging a bit wider to guarantee
Something had to make it. Yeah.
I was a bit slower and a bit heavier. So it was just generally a bit more uncomfortable.
Yeah.
But there's also something to be said for, just like I say, hey, when you sit up, you're likely to feel better. And you do. If I say, hey, tomorrow you're going to be pretty sore.
Yeah.
You will be. And what I found is when I stopped telling, my skills were developing over time, my confidence was, but when I stopped telling patients that they're going to be sore, they stopped telling me that they were sore the next day.
Interesting.
Yeah. And there's some interesting studies there.
Huh. Go ahead.
Yeah, there's this fascinating one where they took a whole bunch of humans, just asymptomatic people. And we know that exercise is hypoalgesic, right? You exercise, your experience of pain drops, your pain pressure threshold increases.
Yeah.
So they measured everybody's pain pressure threshold, their trap and their quad, split them into two groups. Group A, put them up against a wall, have them do a 90-90 wall sit for like 60, 90 seconds. Okay. And they said, hey, this is a really nasty exercise. Your quads are going to be burning. When you're done, you're going to feel awesome. Group B, same thing, but they said, it's a really nasty exercise. When you're done with your quads are going to be burning. When you're done with this, you're going to be thrashed. Group A rechecked their pain pressure threshold.
Yep.
As we would expect, their pain pressure threshold significantly increased, exercise, hypoalgesic, from baseline, both in the quad and in the upper trap, even though it was a quad exercise.
Yep.
Group B not only did pain pressure threshold not increase as it should with exercise,
Yeah.
it decreased in both the upper trap and the quad.
Fascinating.
When you tell somebody to expect a poor outcome, their nervous system will manifest a poor outcome.
I also have to wonder, unrelated, well, not unrelated, but as you've seen less and less soreness the next day, I also wonder how much of that is your improved understanding on exercise application and dosage following the manipulation, which tends to be analgesic. And you wonder the combination of a better narrative, better skills, and more skillful loading following the manipulation. That's a pretty good trifecta for a less sore patient.
Oh, for sure. And embarrassing as it is to say, on the very front end of this game, I had spent some time in engineering school. I was a very mechanical mind. We were doing very specific exercises
I was doing it.
to correct very specific dysfunctions that were all, in retrospect, were all entirely underdosed for anything. And the patients that
so not meaningful.
The patients that were going to get better got better, and the patients that weren't going to get better didn't, and it was their fault, not mine. So yes, I have certainly gotten better at that game too.
Yeah.
And I think understanding true exercise prescription and understanding what the actual mechanisms of the outcome of the thrust are helps you pair them together better. Like if you understand really what you're after with the thrust, then you know how to leverage that change with your exercise.
I love it. You're out there with the Ice Physio team all across. If folks want to learn this stuff, this is a 2-day course. It covers everything. Cervical, lumbar, thoracic, SIJ. I mean, everything baseline skill set you would need is inside that class.
OA to SIJ.
OA to SIJ. How is that spread up across the weekend? Saturday and Sunday? Are you cervical one day, lumbar the other? How do you work through the spine?
We intermix it, right? So
you're not just wailing away on one spot.
and we've got a few lectures spaced in, partly because you've got to really understand the why.
Yeah,
you have to understand the why. You have to understand the population this makes sense in the population that it doesn't. And I think one of the biggest surprises is that you're going to find is you walk in thinking that there's this massive group that it doesn't work for and this small group that it does work for. And we're gonna flip those gauges a bit. But then it also gives you space for your body to reset.
Totally.
And then we mix it up. There's a handful of cervical and thoracic and lumbar day 1. There's a handful of cervical, thoracic, lumbar day 2. And it's designed, the skills kind of build off each other. So kind of everything's raising up together throughout the weekend.
And there's pre-course content to lay the foundation before they're even there. Yeah.
You get a little extra clinical reasoning stuff, and you get where the state of the evidence is on safety. And then once you've digested that, then we create a space in the course to chat through, because it's going to challenge some narratives and things like that.
For sure. I love that. Geographically, you all cover the country pretty, I never keep exact track, but you all are pretty much in all 4 corners of the U.S. every year.
Yep, we're all over.
And you've got a team. It's not just you. They might see Britt out there. You got a whole crew.
Yeah. And it's Britt. So Britt's the other person that leads it. And she's absolutely wonderful.
Britt.
I think, I want to say I met Britt probably 10 years ago when I first started.
She's been a part of the Ice Physio community forever.
And we've been training her up for years and years, and she took over the course as a lead 3 or 4 years ago now. And she's crushing it.
And still in clinical practice on the daily, so just totally incorporating this stuff.
Yeah.
Britt's fantastic. Dude, thank you so much for your time. Thank you so much for the gems. I always learn something when we chat. We'll talk again soon.
Fantastic. Can't wait.